Welcome back to Local Matters on KTLO. We're visiting with Dr. Winmore of the Baxter Regional Bone and Joint Clinic. If you'd like more information or would like to call the clinic for an appointment, you can reach them at 424-4710. Again, that's 424-4710. Visit their website, baxterregionalboneandjoint.org. We talked a lot about hips. What about knees and shoulders?
Knees. Okay. Well, knee replacement is, I think in reality, knee replacement is much more complex than hip replacement because it's a much more complex movement, requires a lot more thought and skill in balancing a knee, where the hip doesn't really require that much. I think the critical thing about knee replacement, which we all orthopedists have come to understand over the last 10 years, is it's not so important what implant you put in, is that you put it in right. I always use the analogy is if you put brand new tires on your car and they're out of alignment, they're not going to last very long. So a lot of the knee has to do with stability and alignment. And it's very difficult to do. And I look back at mine and there's nobody can look back at all their work and say, oh, that is perfect. Because it's very difficult to get within 1 or 2 degrees alignment when you're putting them in with saws and hammers, but there are things we do pre-op. We look at X-rays, we do measurements. We have a system where the computer will tell us and build us a jig that actually makes the cut based on what the information you put in. That's good. It's not perfect, but it does eliminate some of the work that we do intraoperatively. The problem is it can't account for a lot of ligament balancing. So it's not always perfect, but there are things we can do to cut back on that demand in the operating room of getting everything perfectly aligned.
We talked a little bit about a total hip replacement, and that is something, I mean, it does happen when you age. Your total knees, many of us walking and running around here played sports in our former life and have all kinds of different things going on in our knees. Some don't have ligaments, ACL, some don't have cartilage. We've had surgeons say, total knees probably in your future. At what point do you want to kind of look at, say, I'm in good shape now, or I'm in okay shape now, I feel stronger, let's go ahead and do this so I might have more function as I move forward? How do you work with your patients on something like that?
I think you have to sit down and be honest with the patient about what they can expect and the longevity of that prosthesis. Mm-hmm. Just like the tire analogy, let's don't put a tire in you, let's put a knee in you. It's going to last. Let's just use a general 20 years. Let's just say 20 years is, and I always tell patients, 15, 20. Some make it longer. If everything goes perfect and you don't get an infection and you don't fall and break something. So you look at the age of the patient and what is the potential for them needing a revision, meaning to redo this, versus their current lifestyle or lack thereof. What am I going to be able to help them with right now versus what am I going to create for them 15, 20 years down the road? And that's where the patient has to help me make a decision. I don't exclude anybody based on age. It's about how bad. Now, if you come to me and you've got a little knee pain and a little bitty bit of arthritis, you're not getting a knee replacement. I mean, at 35, you're not going to do that. We're not going to do that. But if you come in and your knee is completely destroyed, I mean, you have a horrible knee, you can't walk, but you've got to think, do I make this person suffer for the next 20 years before I help them? And that's where the patient has to be involved in the process of saying, I'd rather, as long as I can feel comfortable that you understand what may happen down the road, we can move on with it. So it's more about
do you want to be knocking on the door of 60 with a potential knee replacement, or do you want to be knocking on the door of 80 with revisions?
Or let's bring that back. Let's talk about a knee replacement at 40 and a revision at 60. You're right. So the revision is the key to that, because unless you're in a situation where you've only developed polywear, which is the plastic little spacer, that's an easy fix. Pop that out, clean up the knee, pop a new one in. It's like getting retreads. You're on the road. But let's say you've lost bone content. It's loosened. Now we're talking about recutting bone. So at 55 or 60, you've lost more bone. Now you've still got 20 years, 30 years to live. You see my point?
I do.
There's a trade-off. So it's all about how much I can make, improve your life now versus what I may create down the road, and you have to be a part of that.
Do you have a most difficult rehab surgery? Is there one surgery you do where you look at the rehab protocol and you're like, that is a tough rehab? Is there one injury out there?
Well, I think complex shoulder issues can be the long, drawn-out rehab. And when we say tough, it depends on what you mean by, is it full of pain or is it a long, drawn-out process? Many shoulder reconstructions, can take 6 months. Mm-hmm. Even if the therapist work with you for 6 or 8 weeks and they get you to the point that you're free to do it on your own, it still may be 6 months to a year before you're back to normal. It's a slow process. So that's probably some of the longest complex fractures with osteoporosis that we cannot allow them to bear weight. They can be sitting in a wheelchair they could be sitting without putting weight on it for 3 months or longer. So that drag, now we just drug that out for 6 months or longer. Mm-hmm. So the complex fractures and then complex shoulder work, I think, are the hardest to get over. Knees, 6 weeks, you're not very happy, but you get through it and you move on. Hips, pretty much a week or two, you're on your own. You're doing well.
Really?
With the anterior approach, I don't say everybody, but if I compare the posterior approach to the anterior approach, the big difference is the time to being independent. In the long run, there's no difference. If you look a year down the road, whether I went in from the front or the back, it's no different. But that immediate recovery time is infinitely better with the anterior approach. Virtually no pain, very little weakness, really a great procedure.
Dr. Winmore of the Baxter Regional Bone and Joint Clinic, it's been a pleasure. Come back.
I enjoyed it. I will. You have to invite me, though.
Yes, sir. Will do. Hey, thanks for taking time to spend with us this Saturday morning on Local Matters. You're listening to Local Matters on KTLO.